Coordinator, Chairperson, Nurse Education, TNA Delhi Branch, and Ms. Dolma, Moderator, Chairperson, Nursing Service Section, TNA Delhi Branch, and all EC member of TNA Delhi Branch, and all faculties and students or nursing officers. So a very good evening to everyone, and welcome you all for our 15th webinar series, Empower Nurses to Empower Nurses. So it is my proud and privilege and welcome our Vice President, National Vice President, North Region, TNA Delhi Branch, Mrs. Annie Kumar, Madam. She is the pillar and great supporter, and she is the one helping us and guiding us for what today the TNA Delhi Branch doing as possible for contribute to the nurses society in Delhi and across India. Because she is all the time motivating us, and because we know that it's a very challenging during the time of COVID, and with Delhi branch able to do so many activities because because of her constant support. Welcoming you, madam. And we are once again my privilege and honored to welcoming two eminent speaker of our today webinar, Dr. Hepzibah and Mr. Rajkumar. Both of them is well connected with me because Dr. Hepzibah, my batchmate during my MSc program, since during her period itself, I knew her very well. She is very unique. She is very hardworking person, and she also the first one who I know that she completed her PhD at Australia, and it was one of the very good study she completed. That was really the inspiration for all of our batchmen, and that really made us to very always be proud about to talk about her. And she's today with us. She's going to deliberate about the topic on how to read between lines for the scientific writing. And Mr. Rajkumar also is also well connected with me since when I joined from AIIMS Delhi, and she was my student in post PSc. She was with me. He was with me for 1 month. But that time itself, I was so inspired with him, and the way he's a very hardworking person. And I am almost 10 years. I'm keep on observing him, following him. He's making a lot of difference in the clinicals, especially nurses working at the clinical. Lot of challenges, but he always he's constantly, he's updating himself, and he used to teach the nurses. He's guiding everybody, especially young nurses, to crack, that CPT exams. The way he's, mentoring them, and also he's a self-motivated person, and it's motivating others also. That's the reason I am always, inspired with him. I have so many students I have gone through in my life. Something is different, and that's why they are all both of them called the empowered nurses. So why we started this, this session? I think most of the time I was deliberated and, just bringing his thought or the concept during the, these programs. The empowered nurses means they are self-motivated and motivating others. And we know that in Indian nurses struggling a lot because the lack of system, and due to lack of system, we are sometimes frustrated and we may stagnated and we may not move further. That make us really become inactive. It has happened with most of the senior nurses, which, or we can see still something we can able to see even our colleague also. But these we can say that empower nurses who are there really something make the differences, because they are all the time they are energetic and they are motivating themselves and others also. That's why we are calling all empowered nurses. So we can call that empower nurses. This can empower others also. This program we are doing, almost we completed, we can say 15th program today, what we are organizing with a collaboration with the TNA headquarters. So once again, I welcome you all to going to hear from these two eminent speakers today. And my best wishes to them. So over to Annie, madam, for her special address.
Ma'am, mic unmute, ma'am. Please unmute your mic.
Okay. Thank you, Dr. Gobi. It is my proud privilege to be here to welcome you all for the 15th webinar. And I'm very proud to see that Delhi State Branch TNA is doing so well in empowering the nurses, because TNA, one of the major main objective of TNAI is to empower us nurses and work towards the professionalism. So you all are doing a great job. And we can see that this is the 15th webinar. So you have done a lot since you have taken charge, and very gladly I am acknowledging your contribution towards the empowering of nurses. And it is seen that you have taken empowered nurses from all over the country. You are not restricted to Delhi State Branch only, because you are taking empowered nurses who are the experts in their own area, and you are taking their knowledge, their skill, and their contribution for empowering nurses in Delhi. So that is to be appreciated, because from the south till till you can say from Kerala to Kashmir, you are taking empowered nurses, experts to deliver their speeches for the nurses in Delhi. So they are highly beneficial and benefited so far. And I can see that the topics you are taken and the knowledge you are contributing towards the nursing profession is admirable. So keep it up, and great work done by the President of Delhi State Branch, Dr. Gobi Chandran, Secretary Mrs. Shaini Chako, and all the EC members. You all are doing a wonderful job, and congratulations to all of you, because it is a model which can be adopted by every state branch. I can say that you all are doing a great work. Keep it up. And about today's webinar, the topics which you have taken is also, as Dr. Gobi has said, it is very apt, and all the nurses from Delhi will be benefited. And I welcome the eminent speakers who are taking these subjects. Today's topic, Dr. Hepzibah Shamil, who is the principal of Chettinad College of Nursing, who will be talking about how to read between lines for scientific writing. So that is a very new topic, you can say, and nurses of Delhi will be highly benefited with this. And also Mr. Raj Kumar, who is the nursing officer, Department of Medicine, AIIMS, New Delhi, who will be talking about ventilator troubleshootings, nursing perspective. So you can see that you are not only restricted to only knowledge or only skills. So both the areas are dealt actually by the speakers. I welcome both of you, both of the eminent speakers for this webinar. I conclude here by again congratulating the great work done by the Delhi State Branch. All the best, keep it up. Thank you.
Thank you, Annie ma'am, for the motivating words. Very good evening to each one of you. I bring greetings to you from TNI Delhi State Branch. The responsibility entrusted to me is to welcome Professor Dr. Hepzibah Shamil SA, who is the principal of Chettinad College of Nursing, which is deemed to be a university at Chennai, Tamil Nadu. Dr. Hepzibah is one of the first few candidates from India to earn PhD with Dean's recommendation for excellent doctoral thesis from University of Adelaide, Australia, which is recognized by Indian Nursing Council and Tamil Nadu Nurses and Midwives Council. Internationally speaking, Dr. Hepzibah S. was the co-chairperson of a major funded project of Australian Research Council, and she designed commemorative services for the government regions of Adelaide, and it was considered for the implementation by the Parliament of South Australia. Ma'am has presented research papers on legal aspects of healthcare in World Community Health Conference and has worked on collaborative projects with Procust USA. And nationally speaking, Dr. Hepzibah S. is a resource faculty, SWAYAM and MOOC of UGC, and undertaken research projects with Inflibet at Shodh Ganga, a reservoir of Indian thesis. Madam has introduced the first 3 minutes thesis, 3MT competition for doctoral candidates in India. Dr. Hepzibah S. has undergone 6 research projects, and she has published 25 index journals, 3 research reports, and 2 book chapters. Now, I would like to invite Professor Dr. Hepzibah Sharmil to take a session on how to read between lines for scientific writing. Over to you, ma'am.
Thank you, madam, for the wonderful introduction and for inviting me. Hope I'm audible. Yeah, I would like to first and foremost would like to thank the Delhi branch for this wonderful opportunity given to me, and also the eminent speakers and the presenters of this day and attendees for the webinar. Reading between the lines for scientific writing is one of the very important thing what has to be done by any of the person who's in the field of science. And nursing to me is one of the important science, and we have to think like a scientist. When I say scientist, a scientist doesn't only use their eyes to read. They have to be very curious to know what's happening now, to know what could be done in the future. Our mouth should share knowledge. Our ears should be open to ideas. Our hands should be very free to do things. And the tools, we should always have a magnifying tool to look at certain things very critically, just not believing what it is said. And our feet also should be very active to walk into places and know things, what's happening. Reading between the lines, what does that mean? It's not always what is said is true, but whenever you look at an article or whenever you want to learn more about nursing, we always read at the previous authors what they have been said. So when we read, it's not only just to know what is read, but also to understand what the author is trying to say in between the lines. Why do we have to know to read in between the lines? Because there are certain things which is informed by the author. The intention of it has to be known. Like if you look at psychiatric research and all, sometimes when you ask the mothers who are very much into downtrodden situation, if you ask them like, how are your children doing, they'll say, yeah, okay, I'm fine. So that answer okay, fine doesn't mean that they're fine. So that is the reason we have to look at this intuitive mind to understand the intention on what the writer is able to say. And it's like a detective reasoning that we have to do. Like if an author is telling about a concept, we have to go into the root of the concept to find out whether what he or she is saying is truth or not. Why do we have to read? We have to read so that we should acknowledge the readers or the persons who have done similar researches in the past. We just can't barge into a research or a nursing activity and then inform this is the first time ever we have done. There's always a prelude of authors or people who have been working in that line. And as a scientist or as a research personnel or as a nursing professional, we have to acknowledge those previous people who have worked in the same denomination. So when we refer and cite more people, it informs that our knowledge and our gratitude towards the science is exemplary. If you look at scientists, great scientists, they spend enormous amount of time reading. However, when we say reading, it's not very easy, because if you want to write certain things like your own article, your own journal, the prelude is about reading. If you are not able to read properly and use your time wisely and manage it in an appropriate way, it's very, very difficult for us to write in a scientific way. That's the reason lots of the publications that we write will not be able to publish, and we have to spend enormous amount of money, even if it's very, very difficult. So when it comes to reading and in writing, time going to be a good friend or an enemy? Probably for TNA branch, I would say it's a good friend, because even after working hours, if you are so much into that appropriate time and working accordingly, my applause to one and all for building it up. So as a scientist or as a nurse scientist, we have to see whether the time is a friend. If you're able to make a time friend, I'm sure we will be able to reach enormous. If you look at it, nearly 1/3 of our time we have to spend in reading for a good writing. So how would we do read? When reading, there's these days, there's overwhelm activities of things which are there on the Google. So whenever we read certain things, it's very important for us to read from the appropriate website. How would we know the appropriate website is? By using academic search engines. Academic search engines, the common platform what we use is the Google Scholar, and also ProQuest is one paid one, which is excellent. And the PubMed is one of the world's biggest resource of science, of scientific search engine. So because it's free, we can't say, okay, it's only PubMed. Actually, it is one of the world proven highest search engines where you can get more enormous things about the research. So it's very important that we are able to search the right thing. And while we are looking at the research in the search engine only, that time, sometimes if you're lucky, liking chudidar, certain ads will come. You know, if you're liking exercise, certain ads will come. So it's very, very important for a researcher or a nurse research to be very focused. If we're going to work only for 1 hour, it is important that we don't get trapped. Even by using a toilet, between that 1 hour, usually scientists wouldn't waste time. So it's like this. If you're going to work between 4 to 6 or 4 to 5 on your writing, it's important that we finish all our activities before 4 o'clock. And then start your reading between 4 to 5. It's just going to be dedicated, and try to avoid any of the traps, like certain things that we will like. So if you're going to avoid that, it's wonderful. And it's all scientists also says, when you're able to read and write, it's very important for us to make a study plan. Like everybody are working, and also these days we have to publish paper to be in good universities and for NAC accreditation and things like that. So we have to make that Paka study plan, such as when are we going to work, what is your family time, and when am I going to sit for my writing. So once you make that study plan for a week's time, they say we have to make a plan for a week. You cannot make like 1 day plan. It's very important you make a week plan that is doable and just stick on to it. So the next thing is study plan. And I'm saying, like, we read, for example, in diabetic mellitus, there could be like nearly 2 lakhs researches could have been done. So when you read, it's important that we read smart and not very hard. If you're able to read an article once, that reading should be very concrete. How can you make that as a concrete? This is the grid that people use. One is, what is the main terminology that is used? What is the associated concept they used, and what extent they had explained it. So if you use this grid, it will be very, your reading will not, you will not be repeating your reading. We can also teach this to our students, you know, like sometimes they will learn on the first month, and by the time of examination, they would have forgotten. Why? Because they have not read it in such a way that they are able to track what they have been doing before. So when it comes to strategy 1, first is you practice smart hard with the literature search grid. And when you read, let's not get tired by reading line by line everything. You know, like second step of reading is to scan. You have to scan. Like, for example, if an article is there for 10 pages, look, if it has got an introduction, look what is there in the index. In the index, what are the subheadings have been covered. So in 1 minute or 1.5 minutes, any reader will be able to know the whole concept of the article. And then if you are really liking, then you go by reading the abstract. So the second important strategy for us to know is about scanning. Don't barge into reading, because everybody will get tired. Only after reading half an hour, we will think, oh my God, I read for half an hour and nothing was useful for my literature. So those traps can be avoided. If first is plan, and the second thing is to scan and read. And then skim. Certain times we will look for the methodology. Like if you want to know about what method, like pragmatic research, pragmatic theory, which is based on pragmatic theory, which is based on action research. So if you're looking at such theory and the methodology, our eyes wants to read certain things. What is about the methodology? That is called as skimming. If you have one page and wherever methodology word comes is where you have to read. So once when you read that, you will know what the author is trying to say about the methodology in coherence with the theory. So the third step is for us to skim and read. Skim, look what you want to read, and then read that with a focus. So your reading will be really good and you can use it also. The next strategy is critical thinking is not a guesswork. Don't assume what the reader is trying to say. For example, certain narratives, slang will be there. General practitioner, in English speaking country, general practitioner is there. In our country, probably they say doctors and physicians. So when they use the narrative languages, we also should remember and learn about that. And the next one is focus on the content. What you want to read, let's focus on it and you clearly understand what it is said. The next strategy is do not procrastinate. If you want to read it now, just do it now. Tomorrow will never come. So that's the reason. Let's make a break. If they say we have 4 hours for a reading, we always break it between 1 hour reading, 5 minutes break, 1 hour reading, 5 minutes break. So that the 4 hours of good complete reading would have been done. So just don't procrastinate, be focused and just do it rather than thinking what to do. You may be thinking this year, one Scopus publication mandate, one top Scopus publication. And like January goes, February goes, for me, years will go like that. So let's plan, make it writing. Writing has got our fingers and our mind has got a very good connection. So make a plan, design it for 1 week. Let's not design it for 7 days also. We are human beings. We need at least 1 or 2 days of rest normally if you want to work really well. So 5 days, 1 hour a day. Make it, plan it and just do it. By the end of the 5th day, we will be very happy to carry forward for the next Monday. So, okay, looking at how to read. Like readers' jogs endure stress. I'm reading word by word. How good reader says we are supposed to read as chunks. Read either 4 words at a time or 3 words at a time. Never read one word, because by the time it gets into your mind and for you to understand, then again there'll be a delay. So let's learn to read words in a bulk, in a chunk of 3 or 4 words. And then by the time when you finish this word, your eyes will automatically go to this and then read at least 3 or 4 words together. And be cautious in reading the hedges. Hedges, like when a person is saying sometimes, it means it doesn't happen all the time. Certain people will say it's possible, which means it has never happened, but it may happen. That is the critical thinking we have to use. And there are certain switchboards we have to, when we read, there are certain switchboards. Like for example, however is one common switchboard. When however will be used? When some author is writing something positive and when he wants to say negative about it, then he will use however. So remember, like it's not when you're reading chunks, when all these switchboards and all these hedging words comes, very important for you to compare and contrast what was the previous sentence informed and what is the connecting word. And then deeply understand the gaps and scope for the future is very important. See, when we are studying BSc Nursing and MSc Nursing, we were just believing what the author says. But now, as a scientist, when you read, we have to understand what is the gap is currently there and how can I fulfill by reducing the gap. So that learning, finding out what is the gap and filling the gap is what we have to do when you're reading. And note taking is very important. Let's not believe too much in our brains. It's always important for us to note what we are going to do. Certain ideas will come by like sometimes 11 o'clock in the night. Just put it. Sometimes some theme also will come. Okay, maybe I will write in this article, in this what is it, title. You will, I'm sure Monday morning when you wake up, you would have forgotten half of the words. So when you have that glimpse of idea, it's very important you put it down, and that's when you will have a remarkable writing when you're going to do it. And when you write, let's have it as a logical flow. One paragraph should only have one concept. Don't mix concepts. Like, for example, if you want to write about tramadol, write about its action for one paragraph, write about its side effects for one paragraph, write about its other dosages in another paragraph. And never start a paragraph with accordingly, however, but, therefore. A paragraph should be a standalone paragraph, and one paragraph should always have one concept only. If you read good articles like Lancet and all, it'll be very simple, flowing, and don't change words. If you're going to use the term registered nurse, use the term registered nurse until you finish your journal or article. Don't use in between other phrases because that will be confusing the reader. Why is he saying something else instead of registered nurse? So that the sequence is very important when you do. And start your engines. Start your engines is the point. As I said, first paragraph, first line is very, very important. If the reader loses his mind by the second paragraph, it means that we have not a good job. So that initial reading is very important, because whenever anybody reads, a portion is not that they will sit in an AC room and then read. Sometimes going in the bus, they will read. Sometimes over the phone, they will read. So when you write, remember that we don't harass the reader, because that's very important. He will lose interest. And let's choose a topic when you're going to read or for your research or for your work that something excites us. Let's not take boring. Everybody will be an expert of anything. Some people will be medical, surgical, cardiothoracic nurse. Some people in education. Whatever your interest is, identify your interest and work on it. And through a good reading, you will know who is the best person in the world. Once you know the best person, then it will be very easy for you to get connected with that person. I have seen lots of people like this who get connected with the top persons in that research because they are working on that research for a long time with passion. I reckon we should do all that. And all these things will be very, very helpful by interpreting the finding, what the real world wants. If you are able to sit here and do an excellent world-class research, it's only because of this they do. And let's bring up that finding in a very conducive way. And remember, every day do a little and do a bit more. What I mean by this is, they say, if you want to read for 1 hour, when you finish, just try to read 5 minutes extra, 5 minutes extra, because tomorrow when you sit again for the reading, we'll be so happy that we have done more reading. Same like that for writing. If you're going to write one paragraph per day, write that paragraph very systematically, scientifically, and then try to write at least 2 or 3 lines for the next day. Next time when you sit, like that will be a great amount of work that is already done. So with this, I would like to encourage one and all to have a good reading and writing. Reading between the lines is highly essential. Thank you.
Thank you so much, ma'am. Ma'am has taken us through a very, a path of reading and writing scientific papers, and how you can do it in a very systematic way and very effective way. So if I have to sum up ma'am's talk, ma'am has initially started by telling us that we now need to, when we are talking about scientific papers, then we need to think like a scientist, and we need to have a critically oriented view in these papers. And not we need to spend time in reading. This is very important. We need to spend time, and time management is also very important, because everybody of us are working. So time management also we need to have. So not only reading, but also understanding the intent of the writer. So while reading paper, we need to understand, we need to try to understand the intent of the author. That is important. And ma'am also has stressed the importance of the source of information from where you are reading. So the search engines, which are appropriate search engines, you should use, like PubMed, this Google Scholar, etc., etc. There are so many. So we need to read from authentic sources. And ma'am has also guided us the importance of making a study plan and scanning the read, skimming what you wanted to read, and then reading in detail about the area of your interest. And very appropriately, ma'am said, do not procrastinate, which I most of the time do. Ma'am, I think now I need to back up and do away with this procrastination. So it's really important, kar lungi, it does not work. You need to start. And I promise you, ma'am, I'll be reading from today now. Okay. So and ma'am has said that you make a routine of planning for writing as well. And while reading, ma'am has given a very interesting tip of reading the words in bulks, and be cautious about the hedges like may, sometimes, etc., and about the switch words like the contrary connecting words like however, etc. So these are important, very small tips, but then very important in reading. And finally, then look for the gap in that area, whichever is of your interest you are reading, and then take notes. And whenever you have any thoughts in between, not only reading, of course, you need to take notes, ma'am said, but whenever, while doing other things also, you may have some ideas, thought process mein aa jata hai. Then you just need to jot down that, and thematic writing, ma'am has given importance to that. In flow, write in flow with thematically you write. So this is important. And at last, ma'am said that read topics of your own interest, where you are passionate about, which will further you will be more motivated to do more into that area where you are interested. So ma'am, thank you so much for this interesting talk. We'll be taking questions later on, ma'am, so I'll request you to be with us till the next speaker finishes his session. Thank you so much, ma'am. Over to Bindu, ma'am.
I just want to add that there are two participants who are joined by MI82 and MotoG. I would like the request the participant to log in with your name. Otherwise, there is a problem in issuing the certificate. MI82 and MotoG. Thank you. Over to Bindu, ma'am.
Thank you. We have another speaker with us to take the session titled Ventilator Troubleshootings, Nurse's Perspective. I would like to introduce Mr. Rajkumar Kanayan. He is a nursing officer in the Department of Medicine, All India Institute of Medical Sciences, New Delhi. He carries with him a rich experience in nursing education and nursing practice, with more than 10 years of experience in his expertise area, that is the intensive care unit, adult medical, surgical, and trauma care. He is a trainer for aspiring nursing graduates to crack government competitive nursing exams like the NCLEX RN exam, which we all know across India. He's a resource person in both international and national forums, and has also presented research papers in both these forums. We are really glad to have you, Mr. Rajkumar, with us. Over to you to take the session.
Yes, ma'am. Yes, I hope I'm audible. Yes, ma'am. Yes. Am I audible?
Yeah, you're audible.
Yeah. Respected Annie ma'am and Dr. Gobichandran, President of TNA Delhi branch, and Bindu ma'am and Shiny ma'am and Dolma ma'am. Fine, good evening, and also my friends and the students. So I hope I'm very happy, pleasure to in this part of this webinar, especially with TNA. So when we are going for this topic, I think this is a very big topic. You can go for at least 3 to 4 hours. But so what we have selected specifically the troubleshooting of the ventilator. Why I just go for this topic? Since we have come across last 10 years in the departmental side where we are lacking as a clinical nurse, we can do as much as we can. So ventilator troubleshooting is the most important part, what I feel. Even many topics are there related to ventilator, but troubleshooting is a part where every nurses who's working in ICU and especially intensive care or any of the departments side where they can handle the ventilators. So they should have at least the basics of knowledge of the ventilator troubleshooting, because this is a life saving, which I can tell, because we usually do troubleshooting and immediate interventions very important, as you know that this is a life-saving measures. So based on this, I just have small session, like I have had only one scenario where we can learn many things. Like one scenario which I added, some of the basic objectives which we are going to deal with this is like ventilator languages. And we have plenty of languages. Usually when you are discussing with the physician, we will come to know. So we usually have some of the knowledges. Ventilator, some people go and stand behind the ventilator and in front of ventilator, and some people just stand backside and they'll see what is happening. So when you are in ICU for more than 5 years, you should learn about the modes of the ventilator, which we are usually writing the notes. If you want to see the live experience, we usually write the notes. So and so patients had this mode, VCV mode, PCV mode, and when you ask them, what is this, what is the function, what is this one troubleshooting which you had during your shift duty, so they couldn't able to answer for this, but we usually write the notes. So as this program is for the empower nurses, we can do it lot in the critical area where you can find out the asynchronies, like ventilator troubleshooting when the patients and the ventilator are not synchronizing. There should be the nurse intervention should be there. If you delay, it may be 5 minutes or 10 to 15 minutes, then it will be the complicated, the end will be the complication, as you all know that what will going to happen. So based on that, I just started with one clinical scenario, which I just want to tell small this one. So I made my one of the scenario, like the patient, usually since I'm in medicine department for last 9 to 10 years. So we handled more than, maybe I can tell more than 1,000 ventilators last 10 years. So when you are going and seeing the conditions, you should know next what to do and next what to do. If the patient is intubated, why the patient is intubated, why it is selectively intubated, or whether it's emergency conditions. Two things which you have to know. Electively intubated is something they're planning, and if it is emergency intubation, is, you know, the GCS less than 8, and I have added the scenario here, and we have the SpO2, which I'll just take the pen. Yeah. So we have the, I just added the SpO2 here, and the tachyphonic and hypotension, and you have the CO2 values, which I added for usually respiratory acidosis is one of the most important condition where we usually they go for intubation. So based on this scenario, what is the role of nurse in these conditions? I think some disturbance. Yeah. What is the role of nurse in these conditions? So basically, I don't want to go for basic, because this is the session which I want to give you the advanced nursing skill, which we can make some changes in the clinical side. So basically, people are aware of the intubations and the ventilator bundle, the basics which we do, usually routine work, we usually do that. Every nurses will do this positioning, ventilator bundle, everything they will do. But what I want to focus, I just want to focus the troubleshooting. Troubleshooting is always a trouble for us, because when you see the alarm, like the red signal, we usually observe, usually we won't see actually when the alarm is there, when it may be high tidal volume alarm, or minute ventilation, or it's a respiratory alarm, it's an apneic alarm. Why this is coming, we usually, I hope so you imagine yourself how many people are observing this alarm and giving the immediate intervention. So this is the critical area where topic which we are usually focusing for the last many years, 2 years. Especially I'm interested in topic because we can save the life of the patients. Because people are aware of the mode. VCV mode, yes, volume control. PCV is pressure control, patient control. And PSV is the pressure support, where the weaning mode. I'm just going to discuss only small thing which you can at least you can remember and you can practice in your clinical. So volume control, those who are not basically, those who doesn't know about ventilator, it may be difficult for them. Those who are expert in that, they can easily got this scenarios. So volume control, we are giving giving completely full depends on ventilator support, and why the volume should be the tidal volume, which we have to maintain the low tidal volume as per the scenario, because the more tidal volume which we are giving, that will cause the barotrauma. That is what the main focus in the VCV mode. Always volume trauma should not be there. That causes even injury as well as barotrauma. And the minute ventilation, the nurses, every nurses who is working in the clinical, they should know the minute ventilation. Why I just want to tell, let us go with this directly with the image which I just want to focus. Troubleshooting, imagine this is the I minute ventilation. Yes, why this minute ventilation alarm is there? We should know why this is happening, because when you are dealing with the ventilators, there should not be any alarms. Alarms should not be neglected. So each and every critical care nurse, I can tell you that why I took this picture. The settings made by the technicians, you can see here 7.20 maximum range and the minimum range 2.40. Actually, we study the physiology. We know the minute ventilation, tidal volume into respiratory rate. That is the formula for the minute ventilation. And the normal values approximately 10 to 12 we can tell. As per the book picture, 7,000 ml or up to 10 it's maximum. 7,000 ml or 10. So here the 7.76 simple scenario, it's under normal. But why the signal is coming? The reason is, here the settings is very important for the nurses. Even though the technicians are, if they are doing the settings, we can able to cross check this setting limit, the minimum and maximum limit. It is set up to 7.2. So these alarms are frequently coming. So what we have to do, just press here and the maximum level should go up to 10 or 12 so that this signal will not come. Very simple. So when the signals are there, alarms are there, you have to go. Even we are going to the bedside for medications. We are going for the rice tube feeding. We are going for the even more than 100 times near to the bedside during the shift. And you never monitor this alarm. And what is the outcome of this? Patient will get affected. So that is what I want to tell here one by one. When you go for alarms, always rule out the settings should be the two limits we have, setting minimum, maximum limit. Like tidal volume, so the settings, the minute ventilation symbol is, this is the V is a minute ventilation symbol. Each and every ventilator, they have this symbol. That normal value of the minute ventilation is up to 10 as per the clinical book picture. So here it's 7.76. So you should not question me, sir, it's normal, why it's alarm is there? Because the settings made here from the ventilator is wrong. Understood? So we have the scenarios, the troubles. Hello. We have the scenarios which we can easily able to identify one by one. This is the VCV mode, volume control mode. We have the PIP pressure, peak pressure, which you have to, nurses should monitor for this, especially when the tube block is there. It should go beyond 30. Less than 30 is a normal value peak. If it is going behind that, the troubleshooting is very important. Immediate rectification should be there. We have to go and see why this is 48. It should be less than 30. It may be mucus plug or any of the blockage, ET bite, maybe of the patients not sedated properly. We have to check it out that. So not learning everything. What is important for the nurses? Tidal volume, which is very important. Usually they'll start from the low tidal volume based on because more tidal volume damage the lung and causes volume trauma. And we have the IE ratios there, specially used for the COPD conditions, inspiratory, expiratory ratio. We have easily can, these are all the things which we can do, even I will do. Simple, when we are knowing the condition, COPD, like I prefer the COPD condition, the CO2 is retained and we have to exhale the CO2 based on the ventilator setting. So what we do usually, especially COPD, CO2 is high in the ABG, we increase the respiratory rate hypo because patient may be in hypoventilation. So the CO2 is retained. So what we do, we increase the exhale time 1:4. So inspiratory, expiratory time we increase to 1:4 so that the patient exhale time will get increased and the CO2 will get washed out. This is a very basic management for the respiratory acidosis troubleshooting. When the patient is having this kind of scenario, we have to understand what is happening with the ventilator and the patients. So these are the parameters which usually nurses will assess. Mostly all the nurses know about what is mode, what is FiO2, what is PEEP, and what is tidal volume, what is rate, if you are good in ICU settings. So what I I want to focus, try to be an advanced nurse, which we are learning everything and we are not practicing in the clinical. So we are lacking our confidence, since we are not learning many things. So it is very simple that we can learn what is PPIC, tracheal pressure, what is plateau pressure, is intra-alveolar pressure, IE ratio is inspiratory expiratory ratio, trigger sensitivity is very important, and auto PEEP is important, auto trigger is important. Why this is important? I usually focus for the nurses who is working the clinical. This is very important. Whenever I go for the shift also, I just observe whether patients are triggering, whether patients having auto PEEP, what happened, this auto air trapping is there, because we are serving the patient going for the pneumothorax. So either we are the one who is there for patients continuously, easily we can monitor this auto PEEP and trigger, which I am going to discuss now. See, this is the next PCV ventilation mode. I just want to tell some of the important, the respiratory alarms are there. So red signal are there. Troubleshooting, what you do, respiratory rate. Okay, we don't want to monitor this. We just give the rails to feeding and go back. Why this high respiratory rate? We have to think. We don't think. The doctors, they will come and think why the respiratory rate is there, and they will call the sisters, come please do the intervention. This why it's better to, we can analyze this why the respiratory rate is high. It may be because of your tachyphonic, because of the immediate post-operative period of usually we see the patients after the tracheostomy, they may be having some anxieties and tachyphonic and pain, hypoxic and fever is there. If you are resolving these conditions, this respiratory alarm will go automatically, right? And moreover, we should know the settings. So settings is very important. Cross-check the settings always. So 40 is there. Here 5 is there. Okay, you know that normal respiratory rate is 24. So we can go up to 40. So beyond that, it is coming 42. So we have to check it out why the respiratory rate is high. So this is one second mode which I want to tell. I'm not going deeply through this one, loops and curves and the mode, because we need at least 3 hours. I'm just giving the scenario which we are facing and we can rectify. Right, this is the second scenario where the respiratory rate will be high and we can easily identify the cause of this and we can rectify. Yes, so here we have the third one is PSV mode. Triggering is most probably people doesn't know what is this -2 and +1 to 3, because this trigger sensitivity is very important. Why we are connecting? We know that alarms are very important. First of all, you should know in the VCV mode, high pressure alarm is most common. Why? Because we are giving the volume high, the pressure we are monitoring. When the pressure is high, the reason is it may be because of mucus plug or because of any ET bite or anything. So immediately we have to interfere and see why the high pressure alarm is that. Peak pressure will be high. So that is one intervention which you have to do. Then we have the PC mode, patient control mode, which always patient control mode may we have the low tidal volume alarm. Why? The reason is patient control mode is like we are adjusting the tidal volume and we are observing the tidal volume and we are doing the pressure. This is the PCV mode. See, you can see the PCV mode. We are giving the pressure 12 here and we are checking the tidal volume, expiratory tidal volume. And you know, it's very interesting. Why I just given this, usually I will tell the settings is 10 here. Tidal volume is up to maximum 500. You know that basic tidal volume is up to 500. Maybe you can go up to 600, 700. The settings made by the technicians are 2000. You can see the 2000 inbuilt settings. So how the tidal volume, if it crosses 500, patient is taking more this one. We are giving how we monitor if the settings are wrong. So only usually we will tell troubleshooting is only important when you are going and checking the cross-checking the ventilators settings, even though the technicians are doing as our role, the nurse's role, we should cross-check the settings limit. Then the alarm easily you can able to find. So there is one guidelines which we usually see when there is an inspiratory tidal volume and the expiratory tidal volume difference is more than 40 or 60, that patients will have pneumothorax. So these are all the things which usually we have to learn because we are the one who we are close to the patients. See here 358 is there and 262 is there. Sometimes it varies, but after sometimes once the ventilator is working properly, the range should not be goes. If inspiratory tidal volume is going 350 and expiratory tidal volume is coming should be 330, 340, 370. It's up and down, not like more than 100. That indicates patient is going for pneumothorax. Yes, and the minute ventilation, I said, see, minute ventilation is normally 10. I'm just recalling you the troubleshooting once again. The settings is wrong. You can see the 25 settings. The settings is 12, 15 is more than enough because normal value is up to 12 or 15. So it's 15 is there and the no alarms are there. When you are giving more pulmonary ventilation, patient will patient will go for lung injury, and that is also, you know, the patient go for pneumothorax, and further there will be imminent death immediately with the patients if you are if the ventilator malfunction is there. So these are the scenarios, small scenarios which I've given you. And you remember that apneic alarm is a dangerous alarm when it is usually comes in the weaning mode, PSV and pressure support mode and CPAP mode. Apnea alarm should not be there. If it is there, that means patient is able to take the breath. PSV mode, when we will give, when the patient is taking complete effort, trigger is most important. Never ignore the alarm, which I want to tell you. Never mute the alarm and check the patient, silence the alarm, and keep on watching what is happening. So don't be like this, without seeing and without hearing and without informing. So this is what a famous thing which we can see in anywhere. But hear the alarm and respond, see the problem, and ask. If you do not know what to do, ask someone. Don't hesitate, don't have the ego, and just ask them who knows, and just go and rectify whether it is problem with the patients or listen to the patients. And pulse oximetry, ABG findings easily you can find out. Chest X-ray doctors will be just ruling out, and we have to check the inspiratory pressure, peak pressure, and the tidal volume, and the alarms, which alarm is there. Why we have to rectify when you are having the some of the important things which I shown in the ventilator. So this is what we usually discussion we will have when the ventilator peak pressure is high and the plateau pressure is low. You can see the plateau pressure. What is plateau pressure? You can see this image. Even I have here also. Yeah. So I have this is the plateau pressure, which is 39. Usually it should not go beyond 30. So peak pressure is also high here, not more than 30. So both are high. I'll just come for the discussion. You can see this in this image, only peak pressure is high. Plateau pressure is not there. Some of the ventilator we have to practice. We have to press this inspiratory pass so that the plateau pressure will come. Okay, so this scenario, which I just go for one scenario here. When the ventilator peak pressure is high, how do you do the troubleshooting? You have to, what I said, mucus plug, ET bite, ET blockage, and the bronchospasm. Bronchospasm is not our role. If you are, so usually we tell when you are doing suctioning at around 9 o'clock during doctor's round, I want to be practical. When doctor's rounds are there, they will call immediately because there is something, peak pressure is high, come and do suctioning. So you have done the suctioning just 5 to 10 minutes before without the rationale. If you do the suctioning and going back and the peak pressure is high, more than 40 and 42, they will call you to do the suctioning because they know the guidelines. So what do? You tell, sir, just now if there's a suction. This is what usually happens. Instead of that, if you are having the knowledge of peak pressure and so and so, and if you are doing suctioning and you go with this parameters, and so that you be very confident that all the parameters are normal. Why we have to? This will be helpful for the because suctioning is very dangerous now. The suction is SOS as clinically indicated. So many of we have seen the conditions like 2 hourly, 4 hourly suctioning. It's not required. It will damage the mucus area, and that further it causes trauma to the lungs. So always, if you know these parameters, why we should do the suctioning, tell them to assess the bronchospasm through the auscultation. Because usually I will tell if the peak is there, normal, and the tachycardia, there is no tachycardia, and saturation is good. We don't want to do any suctioning unnecessarily. You can tell them to rule out the bronchospasm. So they won't tell anything because you have the proof that your peak is normal. Your patient is having good no tachycardia, and they have the saturation is 100. There is no point of telling them doing the suctioning. You can tell them, sir, please assess for the bronchospasm. My side is everything clear. I don't want to do the suctioning. So this is what I want to tell here, especially in the peak. And second one, which I want to tell, if the peak is high and plateau pressure is peak is high, plateau pressure is high. So you have the conditions very dangerous. We have seen during COVID when you are posted in ICU and all, these kind of scenarios were there. Patient is going peak high because very difficult to work with the patients, ventilator, wearing the PP and seeing these scenarios. Even we feel tired and difficult to inform. Immediately we have to do the intervention. Immediately inform to the doctors. Patients going for acute respiratory distress, ARDS, and even COVID-19 patients. Most of the patients went for the ARDS. That those who are in the clinical, and the patient going for pulmonary edema, pneumothorax. This is what I want to tell. Troubleshooting, immediately we have to interface this, check it out why the plateau pressure is high, inform to the doctors to check it out through the auscultation, and if it is high, it may be known case of ARDS or pulmonary edema. Then they have to manage this condition immediately so that we can save the patient's life. right? So this is another important. And then here I just want to tell high pressure alarm, low pressure alarm, people are aware of this, because I don't want to, because many people are studying critical care and they may be knowing high pressure alarm, why this is coming, but still you can see the high pressure alarm symbol is increased secretion, ventilator tubing kinking, patient biting, water in the circuit, and the low pressure alarm is a cuff leak, hole in the tubings, and the leak in the humidifier. So this is what I want to focus. Sometimes we get confused what is happening in the ventilator. It's a high rate. There is a difference between the auto triggering. Auto triggering is one of the most important part. Why trigger is important? This flow trigger, when you see the ventilator is 1 to 3 centimeter, they will keep, or -1 to -2. What is the trigger? Patient is intubated. After 4 to 6 hours, the patient will try to take their own effort. That the ventilator should assess the effort. Okay, for that only they are keeping the trigger sensitivity 1 to 2, 3, because that is enough to assess the ventilator and give the breath. If the patient is, if the trigger sensitivity is more than 4 or 5, the ventilator will continuously deliver, and that create further damage to the lungs. Trigger sensitivity is very important. Why I want to tell trigger, every nurses to know, assess the trigger and auto trigger. Auto trigger is, see, I have given the auto trigger cause, trigger by the mechanism other than the patient effort. That means there is a problem with the patient effort. There is a problem with the ventilators or anything. Immediately we have to interfere. Auto trigger is very dangerous. Continuously either patient may be having this kind of graph. I'm not loops and curves, because this is very big topic. Loops and curves is something different. I'll just tell. Auto trigger, you can see water in the circuit, mostly it happens. If we give the nebulizations, it happens auto trigger. And how we find out the auto trigger? The reason is, which I said in the monitor, when you compare the rate between the monitor and this one, ventilator monitor and the patient monitor, we can see the difference of the heart rate, this rate, we can see the pulse rate. So that also we can easily find out auto trigger, and remove the water leaks if it is there. Nebulizations attached, the most commonly it happens. So we have to easily intervene in this. Auto PIP is very dangerous. It's a air trapping, which the patient is going for pneumothorax. Why this? I have shown the auto PIP graph here. This is what I want to tell. Loop and curves are very important. We are not focusing the loops and curves. I'll show the image. See, this is the normal curves which we should expect in the ventilator. Tidal volume, pressure curve, and loop curves. These curves, if it's going like this, that means the patient is having trapping this area. So usually we assess and we'll tell with the doctor, see the gap which they have. Auto PIP is air trapping. The patient is trapping the air, and that causes pneumothorax. And even air leak, many times we used to assess the air leak. This inspiration curve and the expiration curve end with the 0 axis. There should not be any gap here. This also we find out. Here you can see, I proof with the proof. We took the image with the patient. See the air leak immediately. Whenever I see the air leak, I will take the photo and keep, because for the teaching. So this is the air leak which we have. You can see here air leak. This expiration curve should come to the 0 axis. This is a tidal volume curve. Volume curve never should have the air leak. If you feel that the air leak is there around your night shift, around 1 or 2 o'clock, don't hesitate to change the ventilator. Assess the check the air leak where it is happening. Find out, self-testing the ventilator, call the technicians and check the ventilator, and immediately you change the ventilator, so that we can save the life of the patient. Even though, you know, I usually tell only one thing: give the medication, give the tablet, everything you are doing, and not monitoring this patient who is especially in ICU, not monitoring this closely, and even it is monitored by the doctor, but if you are monitoring, it is immediately informed to the physician, and so that we can easily prevent the complication which the patient is having. So that is what I just want to tell, focus here. Yes. So finally, we have the same diagram which I just want to tell here. I just created the picture. This is the normal curve which we can see, inspiration, expiration coming to the 0 axis. So the complete, it is fine. There is no air leak. When this curve, decelerating curve, inspiration, expiration is going like this, it's fine. It's not going like this. If it is going like this somewhere, then there is air trapping. This and all easily you can assess, very easy to assess in the clinical. When you learn and you assess, you feel proud that even many times you used to assess in the midnight, and you will tell to the doctors, JRs, and sir, please just look it out. This patient is having air trapping, and we used to assess, and we can change the ventilator if the patient immediately, and so that we can make the patients prevent the complications, especially. Right. IFeO2 also is a special thing. FeO2 sometimes we are IFeO2 alarms are there. When you give 55, when you see the patient's SpO2 in the monitor, it shows 100. Yes, 100. So you don't want to think, you don't want to wait for doctors. You can inform them, and you can reduce the FiO2 to 30% or 21%, because patient is maintaining. What is our goal? We have to wean from the VCV, PCV, and PSV, and we have to wean from the ventilator. That is our goal. Ultimate goal of the nurses and doctors to wean the patients from the ventilator as soon as possible. So FiO2, giving the FiO2, patient saturation is 100, and you are not monitoring the ventilator, high FiO2 signal comes. This also I have seen. High FiO2 signal comes, and we usually give side by week, giving the rinse to feeding, and we give the medication, will go back, because we don't bother about this. And this is very important. Why we want to give high FiO2? And if you are going with this immediately, reduce the this one to 21 or 30 in front of the doctors, they won't tell anything, because saturation is good, and they know that you did a good intervention. They won't tell anything, right? And this is one troubleshooting. And the trigger. This is what I tell. When you go to the bedside, your curves, when the normal curves is like this, and if you have any triggering, when the patient is taking effort, the curves will comes in between this. You have to immediately do the intervention. Either you have to sedate if it is in volume control, or if you have to inform to the doctors, because patient is trying to produce their own breath. We have to support this breath. If you are leaving this trigger for more than 5 to 6 hours, patient will go for respiratory drive, and patient will go for respiratory failure. This is very, very important. I want to tell, because the trigger, this graph don't have the trigger. This is a normal graph. You can see the graph, but trigger graph is, we can see here. You can see here. I'll just show this. That PSV ventilator may we have trigger. Yes, just a minute. This one. You can see the trigger. Because weaning more, patients putting their own effort, they're taking their own breath, and the graph is, you can see the trigger is there. So trigger is always, we have to support the trigger. That is the only important role for the nurses. Whenever the patient graph, because loops and curves are very important. As per my experience in 10 years, we usually assess the loops and curves. Immediately we inform to the doctors, and we do some intervention, assessing the air leak and assessing the auto trigger, trapping, and the patient trigger is very important. When the graph shows like this, triggering, immediately we have to two things which you have to do. Either check the sedation, whether the patient is sedated properly or not, or we have to support the patients from the VCV to PCV mode, or PCV to the pressure support mode. Because patients is taking their own breath, we have to support the patients. Okay. Yeah, it may be air leak, it may be ET this one bite, patient may be having bite, and we have to rule out this. And finally, I just come for the final observation. You know that observation where your fentanyl, usually they will start with the all sedated VCV mode. It's sedated with fentanyl, and Richmond agitation sedation scale. Patients should be alert and calm. And if the patient is agitated, then they'll consider propofol and all. So you know that when initially they'll go with the fentanyl and sedate the patient for 6 hours or 12 hours. So slowly they taper the sedation, go for the weaning PCV, and the patient is taking the own breath, they will go for this one. And we used to troubleshoot the patients when in between, when they have any of the this peak pressure is high, when the plateau pressure is high, everything. Beyond that, if you have any problem, even though if you are confused with the intervention, immediately the main important point is immediately disconnect the ventilator, and you should bring the amp bag and do the amp bag with Bain circuit or anything, and you check whether patient's saturation is increasing. Then there is a problem with the ventilator. You have to change the ventilator. If the saturation is not increasing, even though if you do the amp bag ventilation along with the flow meter, and the patient saturation is not increasing, then it's because of the patient condition. The death can appear imminent, and maybe because of the pneumothorax is the most common problem which we have seen because of the ventilator malfunction settings, which usually we have seen in the clinicals. So that can be stopped only by the nurses if they know this interventions. Try to learn and do the troubleshooting is important. As a patient is that it is because of the increased demand will be there, agitation, anxiety will be there for them. We have to check that. Ventilator troubleshooting is because of inadequate ventilator mode settings. That is what we have to assess. When the mode should be there, when weaning mode should be there, when PCV mode should be there, that also should assess. And the circuit may problem, we have leaks, blocks, and water in the circuit. Troubleshooting the ventilator, discontinue the ventilator manually with assessment of resistance. Always use a test lung for the ventilator, which you have in the clinical side. Remember the tube blocks kill the patients, and so we have to remove the effort by the sedation. And finally, some of the condition which we go for the neuromuscular blockade, when to they will start atracurium and everything. When the PF ratio is less than 120, severe hypoxemia, they will consider the neuromuscular blockade. Even this also very important for the nurses. Around in my scenario, I'll tell when the patient is going for severe restless and the patient is going for severe ARDS, only fentanyl is going. So immediately we check the ABG and we see the PF ratio, and the PF ratio is less than 150. Immediately we inform the doctors to please come and see the PF ratio is less than 120. Try to start any neuromuscular blockade so that patient will get completely sedated. Right. So these are all the things which you have to remember and take home message. This is what I want to tell. Every shift you have to check the cuff pressure at regular interval cuff, which you have seen in the ET tube. There should not be any this one ruptured, and we have to re-inflate the, if leak is there, check the circuit junction where the loose and tighten is there, check the water traps where the leaking is there, check the ET tube placement position if it properly or not, whether fixation is done properly 20 to 24 minutes, if it is fixed or not. This, if you are doing this observation apart from the ventilator observation, this is the basic thing where the alarm signal will come. If you are checking this periodically, like every shift you are doing this, and if you are checking all the ventilator parameters, settings and everything, there is no alarm signal, easily patient will win from the VCV to PCV and patient can be extubated. So this is what I just want to tell, because this is very, very big topic. I don't want to go very deep. Just I've given you something which you want to learn and practice in the clinical, which we are doing. If you are also doing, we'll be very happy that all the clinical nurses are very happy to work in the clinicals. We are also very happy that. So never stop learning, because life never stops teaching. So once again, I just thank to Dr. Gopichandran sir who given me this opportunity, and all the TNA members for giving this opportunity for sharing my experience regarding the ventilator troubleshooting. I hope you got something. Thank you, ma'am. This is the session which I think I took 5-10 minutes extra. I was thinking to wind up.
No
But
problem.
anyway,
No problem.
yeah, thank you so much for. Yeah.
Mr. Rajkumar, we can see your passion of being a critical care nurse, and how much passionate you are about this topic, and how much I would say I'm really happy to see such nurses who has interest, who has passion in the area they are working. So thank you so much for this excellent presentation. Though not being in the critical care area, I could grab some of the things which you said, but then those who I think it is very useful presentation for nurses who are into critical care, working into
Yes,
a critical care area. Yes. So the ultimate goal of ultimate goal in the critical care area where patient is on ventilator is weaning the patient from ventilator. That is what Mr. Rajkumar said. And for that, nurses must know the ventilator language, various modes of ventilator, asynchronies, and measures to rectify. So many asynchronies and how to rectify those, how to troubleshoot those. Rajkumar has taken in very detail. Though I don't need to go through this, and I won't be able to actually so like now
it's very big topic, ma'am. So
yes,
very...
I agree. And nurses really play a very important role when there is loss of sync between the ventilator and the patient, and when you can troubleshoot, you can save life. That is the message. And be sensitive to alarms. But having said
Message.
that, it is very important that you need to see the setting and the signals. When there are signals, you need to see the setting, the parameter ranges, minimum and maximum range. It is very important to see those, recheck and cross check those settings and see whether these alarms can be avoided. Am I right, Rajkumar? Okay.
Yeah. That's what important message. You are pointing out the important message.
Yes.
Sure. Yeah.
So, and then nurses' observation, critical thinking with knowledge of all the parameters of ventilator and ways to troubleshoot helps save patients' life. That is what I got to know from this presentation. And an important message which Rajkumar has very nicely told was like, we normally say we follow doctor's orders, but then in his presentation, he very nicely told that while discussing about patients with the medical team, nurses must be aware of the patient's parameters and what nursing intervention you have done. He has given example of suctioning and what further you want from the medical team. So to prevent complication, nurses play very important role in immediately informing the physicians or whoever in service or whoever the appropriate person, and save from complication, prevent complications. So I think hope that nurses working in the critical area will contribute immensely in weaning the patient from ventilator as soon as possible, and giving a comfortable a recovery to the patient. And some of the practical things in troubleshooting, Rajkumar is at the end as a take home message has given. So these are important. Thank you so much, Rajkumar, for this very wonderful and though
Yeah.
heavy presentation, yet it was for me
Yes.
not, in my 2 decades of profession, I've not worked in a critical care area, but still I can understand things. So that means those who are into critical care area,
Yeah.
they really understand, they will really benefit from your presentation. Thank you so much, Rajkumar. And now I think we'll take
Yes, ma'am.
questions
Thank you.
if we have questions, sir.
There is
All are-
Yeah.
there is one question, Dolma.
Uh-huh.
A candidate has asked how to detect ventilator asynchrony.
All the
Yes,
presentations-
whatever I'm telling, yes, that is
Yeah.
ventilation asynchrony. Yeah, I will tell. Asynchrony is a term which is the troubleshooting which I've discussed. Asynchrony is the patients and the ventilator, the triggering which we have seen. If the graphs, if you are knowing the loops and curves, I have not taken the loops and curves because we have the separate big topic loops and curves, the flow curves and pressure curves and everything we have to learn. If you are good in the curves, easily we can find out the asynchrony. Example, I have shown the image where your VCV column is good, that ventilator image, and the next image we see the trigger. Triggering, when the trigger is there, that is the asynchrony will tell. Asynchrony is a term, medical term. Many of the nurses, we don't know about asynchrony. That is a we tell fighting, ventilator is fighting. Sir, please come, ventilator is fighting. Not ventilator is not fighting. That's a ventilator asynchrony term which we have to use that word. Then you can assess whether because of the high pressure, because of the peak pressure, or because of any of the circuit leak or any of the airway leak. So by that only we can assess the ventilator asynchrony. Yeah, asynchrony, actually, this is the full topic is asynchrony only, troubleshooting. I hope you got it, Sonika.
Yes,
Which
sir.
book? Yeah. So Nikita is asking Rajkumar which book to refer.
Sir, ma'am, I referred my Harrison critical care books which we referred, but mostly I usually discuss with the doctors. We learn from them, and usually I'll cross check with some of the trusted critical care website where we can learn from the ventilator. Nowadays Google is there. Not only Google gives the wrong information also, but we have to search exact critical care website where we can learn many things about everything. But mostly we suppose if I learn something when you are dealing with the ventilator, I'll cross check with the doctors. Even sometimes they may be not knowing, and they will tell seniors, and this is right. So by that only we learn. Actually, by experience only we learn. To be frank, I never read any book. Actually, we usually last 10 years by practice and physiology, we know that we have studied BSc nursing. What is the minute ventilation? What is tidal volume? What is peak pressure? What is tracheal pressure? We know that. And what is the malfunction which we have? We compare and we can learn easily. And especially books, Harrison Medicines, and some of the books, critical care PLs, which they have. I don't know exactly author name. Critical care update books, many books are there, ventilator books. We can refer, but only thing, the basic terms which I have shown in the slide, like peak and auto trigger, auto peep and all, you can learn from the Google also, no issue. If you have nowadays the Google online classes, online is everything is available. You can learn if you are understanding the concept. Yeah.
So
normal ranges of ventilator setting. Yeah, peak is less than 30, passive pressure is less than 30, and the peep should be less than 5. Okay. Peak is less than 30. Plateau pressure is less than 30 and the PEEP is less than 5. Usually only COPD, in ARDS patients, we usually keep the PEEP higher level to open the ventilator perfusion, to have the good VQ perfusion. So we usually keep 10 air exchange. Okay. I think PEEP, you are asking about PEEP only, no? Yeah. I didn't go deeply about the PEEP and all because we have plenty of things to be discussed. Superficially I discussed. We have maybe 1 or 2 hours schedule for this to discuss everything.
Okay, thank you.
Yeah.
So there is a hand raised. Jessie Paul, would you like to speak, Jessie?
Good
yeah.
evening. Thank you.
Yes, yes,
Dolma, I must congratulate Rajkumar the passion which he was telling. And to add on to
Yeah.
this, just to remember a mnemonic which I have from my experience, that is DOPE, D for a disconnection of tube, O for obstruction, and P for pneumothorax, and E for equipment failure. So this is one thing that is the troubleshooting which we have to remember. So any problem, the management, he said, has rightly take the patient on bag and tube ventilation and see for it, all the things.
Yes.
Yeah.
Thank you, Jessie. Thank you so much for this add-on.
Yes.
Wonderful,
Yes.
dope mnemonic we all can remember easily.
Yeah.
So thank you, Jessie.
What should be done to prevent?
Yes.
What should be
Thank
done
you.
to prevent subcutaneous? See, I think somebody is asking about subcutaneous emphysema. Subcutaneous emphysema is a complication of the pneumothorax. So, which I have seen in the COVID-19 during the COVID-19 period when we are working in ICU. Many of the patients who went for the pneumothorax and ICD. When you go and discuss this is very big topic because of the ICD clamping. When the patient is pneumothorax and the patients go this one ICD, and when the patient put in the positioning, the ARDS patients prone positioning and all, there is a kinking of the tube and everything which is not monitored from the nurses, and that leads to subcutaneous emphysema. How we assess the subcutaneous emphysema? Easily we can assess by keeping the hand in your thorax area. We can see the air bubble sound, which we have seen mostly. Prevent is only through the ventilator settings. You have to prevent the pneumothorax. Once the pneumothorax is there, you have to be very careful in the ventilator settings, and even ICD tubings. We have to be very careful in clamping and unclamping. If you are mismanaging the clamping, patient will go for the subcutaneous emphysema. Anything else?
I think no further question. We can even have questions for the first session also. Reading a scientific paper. So if you have any queries related to that also, we'll check it right now, together with any questions related to ventilator troubleshooting. What kind of gauze should be used for closing chest drainage?
Okay. You are asking about it. So see, we have the only as per the schedule book picture occlusive dressing, which use the this one sterile gauze which you will apply and made the Dynaplast. And if you want to be practical, we used to have the ICD that Dynaplast and the tube which will occlusively immediately when the tube is dislodged, we immediately apply this occlusive Dynaplast with the small sterile gauze and we'll close that area. That is what we usually do. There is no special thing which we have the special gauze, sterile gauze, which will be available based on your hospital settings. After ICD removal, this is what I'm telling. ICD removal, we can apply the small sterile gauze in the Dynaplast and we can completely close the area.
I think the Nikita is working in ICD. ICD removal is very big topic because ICD is something different. You should know before removal why to remove the ICD. That is also guidelines. There should be 50 ml over 3 days, consecutive 3 days. Only they have to remove the ICD. That also nurses should know. ICD, if it is 50 ml for that consecutive 3 days, then only we have to go for the removal. For your knowledge, extra knowledge I'm giving you. ICD removal. Okay.
I said thank you. So many people have appreciated your presentation, Rajkumar.
Yes,
Alma, I think so it's time to wind up.
Okay.
Yeah.
So I think thank you so much. Thank you, ma'am. Also, ma'am is there around?
Yeah, ma'am is there.
Ma'am, do you have any take-home message to all the nurses present here? If you have, then you have 2 minutes. Ma'am? Is ma'am there?
It's Hepsi, ma'am.
Just now she came and then. Okay, you can just wind up. Vote of thanks.
Okay. So, Rajkumar, do you have anything in general to say to our audience? Just 1 minute.
Yes, ma'am. 1 minute. That's what actually work with the rational. Work with the rational, especially for the clinical nurse, as completely we are facing since I'm in the clinical, many of them we face the social stigma and everything. To overcome this, the only thing the clinical nurses to improve their knowledge in the clinical and to practice that in the clinical. That's the only thing which we usually lack in the clinical. Once you get a job, and we are thinking that only medication and giving this is our role, but we have the plenty of role which to be done in the clinical, and that makes us many things. Yes, we usually have discussion always with the doctors. If we have 40 members, one will be active, remaining will be doing that. They all will having the knowledge, but practicing is not that much there. So I request all the students, whatever you learn, even anything, even IV solutions, fluid, everything you can correlate by clinical only. You can learn lot, and then you can easily prove that you are the clinical nurse. That's what I just want to give the message.
Exactly. Absolutely. So that's why it is said knowledge is power. So if we have the power of knowledge in nursing care, then our image will improve. It is bound to improve in the society as well as in hospital setting and with our own colleagues, medical team. So thank you so much, Rajkumar, and thank you, Ipsika ma'am.
Yes.
Also, if ma'am is around, for the wonderful presentation you both have presented today and empowered us through your knowledge. We have also gained knowledge and you have empowered us. Thank you so much. And thank you to the audience for being here for 1 hour and trying to learn and showing interest in learning. So thank you so much, everyone. And thank you to all the EC members of Delhi branch, Annie ma'am, President Dr. Gopi, Secretary Mrs. Shaini, and Bindu Shaju ma'am, and to the headquarter team, Prashant, and other team who are helping us in from the behind the screen. Thank you so much, headquarter team, and I thank everyone. Thank you so much for being here, and have a good evening. Bye bye.
Thank you, ma'am.
Thank you.